let's talk about lupus, Hablemos de Lupus program webinar. Thank you everyone for participating. We have two great speakers and we're really looking forward to this session. Okay, the two speakers, we have Dr. Jill Bayon she's the director of the Division of Rheumatology Department in the Department of Medicine at New York University School of Medicine. And we have Dr. Donald Thomas, who is president of the Rheumatism Society of the District of Columbia, and he's also the chair emeritus of Medical and Scientific Advisory Council of the Lupus Foundation of America for the DC, Maryland, Virginia chapter. The learning objectives for this webinar are to identify the best practices to help Hispanic patients understand a lupus diagnosis and improve quality of care, enhance health professionals' skills in the diagnosis and treatment of Hispanics with lupus to improve health outcomes, describe approaches tailored to Hispanic patients when diagnosing lupus. Just a little brief information about the Alliance. We are the largest and oldest Hispanic network in the nation's expert in Hispanic health. Our network of community-based organizations service over 15 million Hispanics around the country. The organization does not accept funding from alcohol, tobacco, or sugar-sweetened beverage companies. In the program, Hablemos de Lupus, let's talk about lupus program, seeks to improve Hispanic community awareness and knowledge about lupus and improve healthcare providers' knowledge on diagnosis and treatment. Now, I would like to introduce Dr. Jill Bayon. Dr. Jill Bayon is Professor of Rheumatology and Director of the Division of Rheumatology at New York University School of Medicine. She is also the director of the NYU Lupus Center. Dr. Bayon is internationally recognized as a researcher and clinician specializing in the treatment of systemic lupus erythematosus, neonatal lupus, and rheumatoid diseases in pregnancy. She has published more than 200 papers in peer-reviewed science journals. She has co-authored a book on autoimmune diseases in women, written for a lay audience, and she was the editor of the 5th edition of the comprehensive reference textbook, Systemic Lupus Erythematosus. She has served on the Medical Advisory Board of the Lupus Foundation of America, the Biomedical Research Science Grants Committee of the Arthritis Foundation, numerous NIH grant review panels, review committees for the Alliance for Lupus Research, the Lupus Research Institute, and the FDA Advisory Committee. Dr. Bayon, thank you very much for participating, and you can start.
Great. Thank you very much, and I welcome the audience out there. Clearly, there are many challenges in diagnosing lupus, and I would like to address some of those today. So I think we would begin sort of at the beginning. And what is lupus? Lupus is a chronic autoimmune disease that can affect any part of the body, such as the skin, joints, or organs. And I'd like to clarify some commonly used terms. Systemic lupus erythematosus. This accounts for approximately 70% of all cases of lupus, and in about half of these cases, a major organ or tissue in the body, such as the heart, lungs, kidneys, or brain, will be affected. This is really the typified term describing the disease we generally refer to. Cutaneous lupus, subacute cutaneous lupus, or discoid may be part of systemic lupus or may in fact stand alone because it affects only the skin and it accounts for about 10% of all lupus cases. And some people with lupus confined only to the skin may develop systemic lupus. Drug-induced lupus is very different. It accounts for about 10% of all cases, and it's caused by high doses of certain medications, for example, hydralazine or drugs that are used to treat tuberculosis. The symptoms of drug-induced lupus are similar to systemic lupus. However, unlike systemic lupus, the symptoms usually subside when the medications are discontinuous. That's the difference between what we call idiopathic or sporadic lupus versus where we know or we think we know what causes the disease. And another term sometimes that you may hear about is something called neonatal lupus. This is actually a very rare condition that occurs in the offspring of mothers who have very specific antibodies called anti-Ro or La. And the most characteristic features of the newborn are heart block or a skin rash. But it's important to note that the baby does not have lupus, and some mothers who have anti-Ro antibodies may not have lupus. Unfortunately, the heart block is permanent, but the good news is the skin rash disappears as the antibodies are cleared from the infant circulation. So why is this webinar so important? And I'd like to present 3 scenarios that are quite distinct, but represent the challenges in making the diagnosis. A 26-year-old African-American female presents to the ER with new ankle swelling. Workup reveals lupus with involvement of her kidneys. Treatment with cyclophosphamide is begun, but despite improvement, 5 years later, she's unable to conceive due to ovarian failure. A 36-year-old Caucasian female with established lupus wakes up on her wedding day with a severe red facial rash, swollen joints, and a high fever. And also quite different, but considered lupus, a 15-year-old Hispanic female is having trouble concentrating, complains of hair loss and fatigue, and during class one day falls to the floor and begins having a grand mal seizure. Lupus is diagnosed. So what connects these different case scenarios, and what really is the beginnings or etiology of lupus? Well, we've had 2 fairly famous scientists make commentary about this, both years ago, but these concepts still hold up today. The cause of lupus is based on the loss of immune tolerance to self-components. The autoimmune disease lupus is caused by immune cells that secrete antibodies to the patient's own antigen. How common is systemic lupus? The most recent data from the Center for Disease Control puts the disease incidence meaning of having disease happen in a particular year now, and that is 5.5 per 100,000. The prevalence, meaning how many people out there have lupus, have it established, not how many new cases, that jumps up, of course, to 72 per 100,000. But importantly, the female predominance of this disease is extraordinary, approaching even up to 15 times higher in females than males during the reproductive years. And the peak age is during the childbearing years of 15 to 44. And we put the number of patients in the United States now at greater than 250,000. And these data are very, very recent. Now, let's look at age-adjusted prevalence of lupus among New York City, Manhattan residents in 2007, as per the ACR criteria I'll discuss, and particularly among women. What is really interesting, and this is a survey strictly done in Manhattan, and you can see on the right the different color schema that go to the different races and ethnicities, and you'll notice Hispanic, which I've circled in green. You can actually, if you look through all the graph along the x-axis, which is showing you age, and the rates are on the y-axis, you can actually follow along, and astoundingly, for a Hispanic woman of childbearing age that happens to live in Manhattan, lupus can be present in 1 out of 500 cases. So while we consider this a rare disease, I think we could take a step back and say someone you know might have lupus. So how does lupus begin, and what do we consider sort of the phases of lupus? And this is very simplified, and I'll actually go through 3 slides to help think about sort of how lupus comes about and how it may evolve and progress. So we think that there is a genetic predisposition, that there are genes which may amplify, there may be genes that you don't have that would have otherwise been protecting, and certain race, ethnic backgrounds are more susceptible to lupus, and I think it was already clear that Hispanics are among a more susceptible group compared, for example, to Caucasians. So we have environmental clues, environmental things that may augment lupus, such as UV light, and we're very cautious about telling people to be protected from UV light. Some viral infections may have a place in potentiating or initiating the disease, and perhaps other infections. All of this results in defective immune regulation and effectively breaking self-tolerance. And I'm not necessarily going to go through all the different players. I'll have that on the next slide, but this immunologic breach results in the formation of autoantibodies. Autoantibodies can form immune complexes. Complement can then be deposited in organs, which cause inflammation and clinical disease, as we've mentioned, brain, kidney, joints, skin, heart. Eventually, if the disease is not kept in check, and we try very hard to do so, some of the organs may become damaged. We try to avoid that, and I should point out, not every patient, just because they have a flare, will wind up damaging the organ. But that's why this is so critical to recognize, because eventually, if the organs fail, you can get kidney failure, atherosclerosis, and in the case of a little baby, congenital heart block. So this is sort of an oversimplification of the pathogenesis, but ideas that we have in the way we look at targeted therapy looks at trying to stop one of the processes in this kind of grand scheme of the immunologic aberration. So cells can die, and cells can release material that, for example, DNA and RNA, self-components that can be taken up by cells called plasmacytoid dendritic cells that can then secrete a cytokine called interferon. And you'll hear that there are a lot of therapies now that are directed against stopping that load of interferon. The interferon can affect certain of our white cells, have our white cells die, that then release DNA that can be taken up by B cells, and antibodies to DNA can be made. We all have heard of those. Meanwhile, if we look back to the left side of the slide, some of the debris of the apoptotic cell can be taken up by an antigen-presenting cell, which then can talk to the B cell through the T cells, eventually resulting in autoantibodies, complement activation, and deposition in tissues. And just to put this one more time, the influences of genetic, environmental, immunoregulatory, even possibly hormonal. Obviously, we've talked about women having the disease more than men. And then something called epigenetic, which is a way of sort of changing the genes through environmental influences. And all of this conspires to affect the organs that we've just mentioned. So lupus has genetics. There's clustering in families. The concordance rate in monozygotic twins is about 25 to 30%, and dizygotic 5%. So that immediately tells you that one genes may be important, but genes are not the whole story. So we've been looking over the years with family-based studies, basically thousands of patients being evaluated for their genes, and we've come up with certain what we call SLE risk loci. These are genes that put you at greater risk for developing a disease such as lupus. And it's not surprising that these genes cover areas that we just discussed about in the pathogenesis. For example, relating to immune complex processing, taking up antigen by toll-like receptor, interferon pathway, and immune signal transduction. But I would point out there isn't one gene that is, if you have it, you'll get lupus necessarily. The closest is something about dealing with C1q, but in general, it's a multigenic problem, meaning that you need a lot of genes to get to the point of developing lupus. So lupus really, we talk about lupus diagnosis and we talk about lupus classification. And just to point out that if we want to diagnose a patient and have everybody in agreement about what that might be, it would be helpful to use criteria. And although people refer to these as classification criteria, I can certainly say in my own practice, I apply these criteria, I discuss them with patients so they understand the features that comprise the diagnosis. And to have lupus, to be in a research study, you would have to have 4 of these criteria: butterfly rash, discoid rash, photosensitivity, oral or nasal ulcers, arthritis, fluid around your heart or your lungs, affecting the kidney or the brain. And and or laboratory abnormalities such as low white count, low red count, low platelets, anti-nuclear antibodies, or very specific antibodies. To have lupus, to be said to have lupus, 4 of 11 criteria would be present. It's useful to go over these with patients because if they don't have these criteria, at least they understand what to be looking for should any of these develop to make sure they call you about them. Now, new criteria have come forward over the years, and they're similar and require at least 4 criteria, being 1 clinical and at least 1 immunologic. Hair loss has been added as another criteria for lupus, but importantly, some individuals may have kidney involvement alone and not what we call the extrarenal manifestations. Those patients can be considered to have systemic lupus erythematosus. So why is the diagnosis so difficult? Well, those features that I just discussed can happen over time. You might have low platelet count 10 years ago, and 10 years later, you may develop a facial rash or joint problems. So we have to keep in mind it's a constellation of signs and symptoms over time, and that not all are necessarily present at once. Important for doctors to take a comprehensive history. If you don't take a comprehensive history, you're not going to find out about the fact that this patient had a low platelet count 3 years ago. And if you're a mathematician at heart, 333 patients can have a different set of 4 criteria. Now, does that sound daunting? So there are also some supporting features. While they're not criteria, hair loss has become criteria, but if we only use the ACR criteria, that wouldn't be there. Fatigue, many lupus patients have tremendous fatigue. That is one of the most disconcerting aspects of their disease. Some have fevers, not due to infection, and some patients have color changes of their fingers called Raynaud's phenomenon. And then there are comorbidities. People with lupus have a higher risk of having atherosclerosis, and there's intense research to try to understand why that is happening. Now, not all lupus, it's pretty obvious from what we've discussed, is the same. There could be mild lupus where you have only a rash, oral ulcers, or arthritis, or fatigue, but there may be severe forms. Your rash is so disfiguring you don't want to go outside. Your kidney disease is significant. You're not thinking straight. You have seizures. Your blood counts are dangerously low. You're bleeding into the lungs. Obviously, we're looking at very different types of patients. But the scary part of it, and why it's important to be vigilant, even if you're on the mild side of the spectrum, the picture can change. So it's a challenging disorder. The activity and severity should be assessed repeatedly over time. The presence of new signs and symptoms have to be assessed. Looking out for worsening of signs or symptoms, and importantly, to monitor blood tests to predict and verify flares. And importantly, people with lupus may develop kidney disease and it may go clinically unnoticed. So it's important to follow with physicians. The clinical pearl, ANA. We think of ANA as the hallmark of lupus. It is very sensitive, 95% sensitive. But its predictive value is very poor, meaning out there are many individuals who could have an ANA and not have lupus. So an ANA is really important as a negative. You don't have it, it's very likely you don't have lupus. This is important. On the other hand, misdiagnosis can go both ways. It takes an average of about 4 years and 3 physicians for the correct diagnosis. Now, this is a slide that we commonly use in some of our teaching portfolios. I would emphasize and hope that for rheumatologists, it won't take 3 rheumatologists to make the correct diagnosis. But the important aspect is most of these patients, the first line of interaction with the medical profession, in fact, is with the primary care physician. And you have to think of lupus to diagnose lupus. 32 million Americans have a positive ANA. So we understand that a positive ANA alone does not mean lupus. So many physicians get ANA consults, and a lot of our job is to reassure particularly young women where about 15 to 20% of young Hispanic women who might be complaining of fatigue or might be otherwise totally healthy out there could have a positive ANA. And we have to be important that we ask the rest of the questions and don't say only because you have a positive ANA, therefore you have lupus, because that's not true. And just kind of to wrap up, there are certain antibodies that are seen in lupus that associate with various specific manifestations. For example, anti-DNA is a hallmark of lupus. Unlike the ANA, this is a very, very specific test. If you have anti-DNA, you're very likely to have lupus. There's the positive predictive value. And it's associated highly with the development of kidney involvement. Anti-Smith is another particular autoantibody doctors will test for, anti-RNP. This can be associated more with arthritic manifestations, anti-Ro, dry eyes, photosensitivity, having a child with neonatal lupus. And antiphospholipid antibodies stand in the class by themselves because they can be associated with thrombosis, stroke, fetal loss, and thrombocytopenia. And then why we need to do better, to wrap it up, even though there have been terrific advances in lupus, it really is a reason to take pause. A patient in whom lupus is diagnosed at age 20 years of age still has a 1 in 6 chance of dying by the age of 35, most often from lupus or infection. Thank you.
Thank you, Dr. Bayon. That was a great presentation. Now we can move to our second presenter, Dr. Donald Thomas. Dr. Donald Thomas is a rheumatologist who has a special interest in lupus in his private practice in Greenville, Maryland. He is especially interested in helping patients who suffer from lupus, inspiring him to write a highly acclaimed patient education book called The Lupus Encyclopedia, a comprehensive guide for patients and families. Dr. Thomas is the president of the Rheumatism Society of the District of Columbia. He is also very active on Medical and Scientific Advisory Council of the Lupus Foundation of America, the DC, Maryland, Virginia chapter. And he has served as the previous chair as well. He also enjoys teaching other physicians and medical students about lupus at the Uniformed Services University of the Health Sciences, where he served as an assistant professor of clinical medicine. Welcome, Dr. Thomas. You can start.
Thank you to the National Alliance of Hispanic Health for having me to this webinar. Lupus is near and dear to my heart, and I do love teaching other physicians and healthcare providers. As Dr. Bayon was just discussing previously, systemic lupus erythematosus can look very similar to other disorders, and we call it the great mimicker because it can pretend to look like other diseases. It can affect every single organ system of the body. It can cause a lot of lab abnormalities that can be seen in other diseases. For example, let's say you have someone with severe rheumatoid arthritis. They'll have an inflammatory polyarthritis. If they have Felty syndrome or LGL syndrome, they can have a leukopenia. Rheumatoid can cause pleuritis, as well as 30% of rheumatoid patients can have a positive ANA. So a patient with severe rheumatoid can actually meet 4 criteria, those classification criteria that we talked about, but that patient does not have systemic lupus. That patient has rheumatoid arthritis. And this is one reason why I think it's incredibly important that any patient you suspect of having lupus be seen by a rheumatologist who has a special interest in lupus to help sort through these difficulties. Another disease that can look very much like systemic lupus is parvovirus B19 infection, which especially loves to cause inflammatory arthritis in adults. It can also cause leukopenia, positive ANA, and a fair percentage of them can actually have that double-stranded DNA that Dr. Bayon talked about. We consider it to be specific for lupus, but we can see it in parvovirus infection as well. So whenever you see a patient who looks like they may have lupus, you always want to check an IgM parvovirus level to make sure that it's not parvo instead, because this patient also fulfills 4 criteria, but it's not systemic lupus. And so there can certainly be some difficulty in sorting out these different things when you're looking at someone who may have lupus or not. As far as the anti-nuclear antibody test, as Dr. Bayan said, it is common in the normal population. Depending upon which laboratory method is looked at, 20% to 30% of healthy people can be positive for ANA. Any type of inflammatory disorder can cause a positive ANA, most likely related to the overstimulation of the immune system. So people with infections, cancer, and any autoimmune disease, to include hypothyroidism, can cause a positive ANA. Medications, as well as a familial diathesis, people who have other family members who have systemic lupus or other autoimmune diseases have a higher chance of being positive for ANA without actually having systemic lupus themselves. Another very important thing is that antibodies that we see in lupus can occur many years before the disease. I recall back in the 1990s when we would see patients who were positive for ANA and maybe an RNP and SSA antibody. When they would see a rheumatologist and were evaluated, if they didn't have anything else going on for lupus, oftentimes they were told they don't have lupus and were told, you're great, you can just go away and see your primary care physician. But in 2003, a very important study was done in the military where they looked at old repository blood samples, and they were able to show that 5 to 10 years before the diagnosis of systemic lupus, that RNP antibody, SSA, SSB, anti-Smith, double-stranded DNA, and rheumatoid factor can all occur many years before the actual onset of disease. So today, if I see a patient who's positive for any of these antibodies, but otherwise they can't find any evidence of systemic lupus, I do recommend that they follow up with me regularly, and I teach them about the symptoms of lupus, just like Dr. Bayan had mentioned, so that if they develop any of them, I want to see them right away in case they may have it. If they have these autoantibodies, they are at increased risk of potentially developing lupus in the future, and it's so important that we educate our patients about this. A disorder I'd like to mention is something called undifferentiated connective tissue disease, or UCTD for short. Undifferentiated connective tissue disease is the term that we give to someone who has evidence of a systemic autoimmune disease, but they don't meet full criteria. For example, if I have someone who has an inflammatory arthritis, low white blood cell count, and positive ANA, they have 3 criteria for systemic lupus, but I probably would not diagnose them with lupus. I would most likely call them undifferentiated connective tissue disease because they don't fulfill all the criteria. So if someone has manifestations of an autoimmune disease but don't fulfill criteria, we do call it UCTD. And these patients make up between 15% to 25% of rheumatologist practices as far as when you look at their patients who have systemic autoimmune diseases, 15 to 25% have UCTD. I would say, though, that today we actually have these numbers actually come from the 1990s, and I would say today about 15% of our patients with systemic autoimmune disease have UCTD. Nonetheless, this is a real disease, and I do tell my patients that because sometimes they feel like they're in limbo and that they don't really have something, but it truly is a real disease. It's just on the spectrum of autoimmune diseases at the milder end, and we treat it the same way. If they have an inflammatory polyarthritis, we'll treat it with Plaquenil and methotrexate, just like we will with the patient who has systemic lupus or rheumatoid. There are other names that are used. There's no one definition of what we should call these patients, although UCTD is the most common term we use. But if you see undifferentiated systemic rheumatic disease, undifferentiated collagen vascular disease, lupus-like disease, possible lupus, probable lupus, lupus variant, latent lupus, and incomplete lupus, these all refer to the same thing, undifferentiated connective tissue disease. So what is the prognosis of someone in whom we give this diagnosis? Well, 10 to 30% of the time it does go away on its own, and in those cases we feel that it's most likely a self-limited mimic, such as an infection that caused the symptoms, and the good news is that it does go away and stay away. 50% of the time, the patient stays the same without any worsening, but about a third of the time, these patients will evolve over time to full-blown systemic lupus, rheumatoid arthritis, scleroderma, Sjogren's syndrome, or one of the other systemic autoimmune diseases. In my patients with UCTD, I do recommend that they consider my placing them on Plaquenil or hydroxychloroquine, and that comes from a 2007 study which showed that patients with undifferentiated connective tissue disease who take hydroxychloroquine regularly are less likely to develop severe systemic lupus over time. Autoimmune diseases can also evolve over time as well. They do share many of the same genes. As Dr. Bayan alluded to, there's well over 50 genes that have now been identified that predispose to people having systemic autoimmune diseases, and many of them share these same genes. Also, these diseases share many of the same problems. They all can cause inflammatory arthritis. Many of them can cause rashes. All of them can cause pleurisy, Raynaud's phenomenon, and interstitial lung disease. They also can oftentimes cause the same laboratory test results, especially the anti-nuclear antibody, rheumatoid factor, RMP antibody, SSA, histone, and single-stranded DNA, which is different than the double-stranded DNA. So if we see a patient who has any of these antibodies and just one or two of those other problems, we'll oftentimes call them undifferentiated connective tissue disease and see if they develop a specific autoimmune disease over time. These diseases can start off slowly and evolve. I'll just give you an example. Let's say that someone presents with a symmetrical inflammatory polyarthritis and they're found to be positive for rheumatoid factor and ANA, and the physician will be wondering, could this be lupus or could this be rheumatoid arthritis? If nothing else develops, that person actually satisfies classification criteria for seropositive rheumatoid arthritis and would be treated as such. But let's say after a few years, the patient develops some proteinuria and is found to have nephritis, develops a malar rash, and positive Smith antibodies, which are very specific for lupus. The diagnosis at that time is systemic lupus erythematosus. There's two possibilities on what's going on. One possibility is that the person could have had systemic lupus the entire time and now has developed and just started with inflammatory arthritis, but now has developed the other problems. In fact, I just saw a patient of mine this morning who's had UCTD for about 10 years, and recently she's been under stress, and now she's developed oral ulcers, which is a new problem, along with her inflammatory arthritis, and now is developing low complements, so she now clearly has systemic lupus. Or this patient may actually have an overlap syndrome. It's very common for people to have more than one systemic autoimmune disease, and for example, if this patient develops erosions and ulnar deviation of the hands, as well as having her lupus, we would say that she has overlap of rheumatoid arthritis and lupus, or what we like to call rupus. So how common is lupus in the United States? Dr. Bayan already went over the most recent data. About 18,000 Americans per year will develop systemic lupus, and the prevalence is around 250,000 people in the United States. Its more common onset is during childbearing years, but all ages are affected. We have little children who have systemic lupus, and even the elderly. Just last year I had an 85-year-old man who presented to me with classic systemic lupus. Everyone is not affected equally. There is a large predominance in females. 90% overall of United States patients with lupus are women. Part of that probably has to do with the influence of female hormones, but also many of the genes, or some of the genes that Dr. Bayan had mentioned, are actually located on the X chromosome, making it more likely for women to develop systemic lupus. And systemic lupus is 2 to 3 times more common in women of color, and that represents, again, probably the genetics that are going on in Hispanics as well as African Americans, in whom lupus occurs more commonly. A very important study that I like to mention is called the Lumina study. This was started by Dr. Alarcón. She's a lupologist at the University of Alabama. In 1993, the National Institutes of Health wanted to start studying minorities in the United States more closely regarding chronic disorders. And so she started a study called the Lumina study, which stands for Lupus in Minorities, nature versus nurture. And she wanted to include patients who are Hispanic as well as African American and compare them to other ethnicities, especially Caucasians. And now we have a very large patient population in Alabama, Texas, and Puerto Rico that have been followed for the last couple of decades to see how lupus affects Hispanics compared to other ethnicities. And what Dr. Alarcón and her counterparts have found is, number one, patients who are Hispanic have more severe disease overall, especially nephritis. Except something very interesting about it is that they feel that it's not just the ethnicity that plays a big role, but that there's big socioeconomic factors that also drive the severity of disease. More severe disease is seen in patients who have more poverty compared to affluent Hispanics, and so it's not just the ethnicity, but the socioeconomic problems as well, which of course is a big problem in African Americans and Hispanics. Lupus occurs at an earlier age in Hispanics. It also has greater disease activity at the time of diagnosis, and again, this probably reflects the socioeconomic problems and the lack of access to better health care. And also more neurological problems occur as well, such as seizures, cerebral hemorrhage, and stroke. And by the way, the Lumina study, I think it's a really important study. If you want to learn more about it, just go to Google and type in Lumina rheumatologist, and you'll find a very good article by Dr. Alarcón about how she started it and what the study is finding out these days. And she also likes to point out that Lumina comes from the word light. And so this is shedding light on the importance and problems of lupus in the Hispanic community. So what are the experiences of healthcare professionals with systemic lupus in Hispanics? And I'll just like to preface this that these things are not just occurring in Hispanics, but also other ethnicities as well. First of all, denying or doubting the diagnosis, and I especially see this problem in my young patients who will have denial about having systemic lupus. Many of our lupus patients actually don't feel too bad, especially when they have early mild disease, and this can cause great difficulties with compliance with taking their medicines. And I've had just way too many patients come back to me after several years of not taking medicines and then show up on my doorstep with severe nephritis. And so it's really important that we educate our patients as soon as we give them the diagnosis about how important it is to take their medicines regularly in order to prevent evolution of their lupus into a more severe disease. There's also a lack of knowledge. Many people, to most people, have never even heard of lupus, so it's very important that we educate them about the disease to help with the compliance issues. Many patients are not familiar with chronic diseases versus acute diseases. There's also a potential problem with magic ideas about the causes of lupus, and I think this has more to do with patients who maybe come directly from Latino countries such as Central America, South America, and Mexico. I talked to a couple of my medical assistants who were born here in the United States, and they tell me about their grandmother and grandfather having them use certain remedies, for example, remedios caseros, which are home remedies, and remedios naturales, which are natural remedies, oftentimes bought at stores such as botanicas. And so they may think that diseases have some type of magical cause rather than a medical cause, and it's important that we educate these particular patients about the medical side of things and try to convince them to take Western medications. Poor compliance with consults, treatment, and recommendations is a common problem, especially if there's a lack of education and difficulty with access to insurance. Treatment can be driven by symptoms, and this is a common problem. It's really important that we educate our patients about the importance of taking their medicines. A lot of my patients will tell me during their visit, oh, I feel perfectly fine. I don't even feel like I have lupus anymore. And I say, perfect. That's exactly how I want you to feel for the rest of your life. And please don't stop taking your hydroxychloroquine or your other medications. Because some patients will stop their medicines because they feel great and they feel like they should have only taken it when they had the arthritis or were feeling poorly. Many patients will have the fear of prednisone and immunosuppressants, and this is when it's important for us as the healthcare provider to teach them about the risk versus the benefits, about how prednisone can be a life-saving disease in many of our patients, and that even though immunosuppressants have a lot of scary side effects, they can get our patients into remission, and systemic lupus itself is much worse than the medications themselves. And then family influences, which play an important role in Hispanic culture as well. There's a lot of misconceptions among Hispanics about lupus, and again, I'll say that I don't think that this is just for Hispanics, but other non-Hispanics as well. Number one, a lot of people know a lot of women who are affected with lupus, and so don't think it affects men, but 10% of men do have it, systemic lupus. My male patients, I like to refer them to YouTube, where Nick Cannon actually had severe systemic lupus with severe lupus nephritis, and he has a wonderful documentary on YouTube that he calls his incredible health journey, and many men are surprised to see how sick Nick Cannon was with lupus, but how now he's doing so well because he's compliant with taking his medicines and he works so hard on diet and exercise. Many people may think that lupus is caused by other things, such as infections. It's important that we teach them that it's actually genetic and due to environmental risk factors, as Dr. Bayan mentioned. Nutritional factors. A lot of people want to blame their diseases on their bad diet, which is not the case with lupus. However, there are some foods that may actually decrease inflammation and some foods which may actually make lupus worse, and so it is important that we do teach our patients about those things, but it's not diet-driven in total. Many people will think that a positive ANA means that they have lupus. This is a very common problem that we see as rheumatologists. We'll see people with a positive ANA who are convinced that they have lupus, and then it can take a lot of convincing to teach them that 20% of the population could be positive for ANA. And by the way, I'll just mention at this point, there's a brand new blood test that I just absolutely love called the SLE-Key test. This is a test made up of hundreds of antigens and antibodies, a microarray test that can actually rule out lupus. And I like this test because when I show it to a patient, for example, who has fibromyalgia and ANA, and it can show that they actually don't have lupus, which is just fantastic. It's called the SLE-Key test, K-E-Y. Some people think that children should be tested for lupus if their parents have it, and of course there's no test for lupus. It's more important to teach your patients to teach their children about the symptoms of lupus, and if any of the symptoms occur, then that's when they should see their physician. Some people think that pregnancy is contraindicated, and this is Dr. Bayan's specialty. Thankful to her and her counterparts, today the vast majority of our lupus patients can have a successful pregnancy. In fact, with the things that Dr. Bayan has taught me and my other rheumatologists about how to take care of our patients, if we have a patient with systemic lupus and if we have them in remission for 6 months and then keep them on hydroxychloroquine throughout their pregnancy, as well as do a lot of other micromanaging, most of our patients actually have a successful pregnancy, which is just amazing. Some people will think that all their symptoms are due to lupus. Remember, lupus oftentimes affects young people. As they get older, they like to blame everything that happens on lupus, but it's important that we teach them that not everything is. For example, patients with lupus can get psoriasis and eczema, which are rashes that are not even related to lupus. So it's important that a physician think of the total patient and all the different possibilities in their lupus patients rather than just lupus as the cause of anything. Some people will think that control of the disease is impossible. Well, today the treatments are so good. In a community setting such as mine, which is, I'm not a tertiary care center, but I'm in private practice, and all my patients have very good access to health care. Most of my patients are actually in remission or in clinical quiescence on treatment, and that's what I stress to my patients. If they're totally compliant with their treatment, they can actually achieve remission much of the time. And so we won't need to give them that optimism that they can take control of their disease and that they don't have to succumb to the disease like all the scary stories that they hear about on the internet and from friends and family. There's some Hispanic cultural norms regarding the patient-provider relationship. For example, respect, or in Spanish, respeto. And this is where Hispanic people may not question the physician's authority because of their rank. And this is a common thing in Hispanic cultural relationships, is to have respect for elders and people in authority. But because of this, this can sometimes cause problems. For example, the patient may not question what they're being told. They may disagree with what they're being told, but may not say so to the physician. They may feel a sense of shame for not understanding the provider. And as a result, they may not ask any follow-up questions and therefore may not be compliant with their treatment, which can adversely affect their health, of course. And so as providers, it's really important that we proactively ask or encourage our patients to ask us questions and to become an active part in their health care. We don't want them to just take our word for everything and go away not understanding exactly why we're recommending what we're recommending. Politeness and the formal friendliness is very important in the Hispanic culture, or what they call simpatia and personalismo. For my medical assistants, they tell me that, for example, when they were children, their parents, if they had a big family reunion, they just couldn't come in and say hi, just hi and wave their hands. They had to go up to each elderly member of the family and give them a kiss on the cheek and introduce themselves and tell them who they are, because that shows respect for their elders. So when you see someone who's Hispanic, it's really important that you shake their hand and have a nice big smile on your face, make them feel welcome inside your office. Also, communicating in Spanish, even if you know a little bit of Spanish, can make a huge difference. Saying hola and como se siente, how do you feel? When you first meet them, and say mucho gusto, boy, it can bring a huge smile to your patient's face because you're showing respect for the person and their language. So learning the polite words in Spanish can go a long way in forming a good bond between you and your patient. The uncertainty avoidance, or what's called fatalismo. Some people will have a belief that there's very little that they can do about their fate. They'll think that their future is determined and there's not much that they can do. But it's really important that we teach the patient that they do and can have a lot of control over their destiny and getting their disease under control. And that does take a lot of education, and it can be done. Strong family values are very important in the Hispanic culture, or what's called familismo. I encourage my patients to bring their family members along with them so that, number one, they can interpret for me better so that they can understand what's going on and what I recommend, and also to engage the family in being a proactive help with their health care. And so using clear and straight questions are very important in our patients. And then most importantly of all is, of course, to listen carefully. And so I really appreciate the National Alliance for Hispanic Health in having me here today. And I think this is a good time to open up to any questions that any of the listeners may have for me and Dr. Bayan.
Okay, thank you very much, Dr. Thomas. That was also a great presentation. I want to thank both of you for participating in today's webinar. And now we have some time for questions. And I also need to let the participants know that those participants from Texas, from the state of Texas, will be able to receive CEU credit for their participation in the webinar. So when this webinar is concluded, we'll be sending them the survey they need to complete, and then where they need to send it to so they can receive their credit. So I wanted to let everybody know for those participants in Texas. Now, we already have a couple of questions. Now, one is, could you have lupus if you have hypothyroidism?
Yes. Yes. Yes, you can.
In fact,
we can go into that, but go right ahead.
In fact, what I like to tell my patients is that hypothyroidism is actually an autoimmune disease, and it's very common to have lupus and have lots of family members who have thyroid disease.
Absolutely.
Okay, and now the other question is, I have a question here. So, Dr. Thomas, I believe you mentioned that nutrition is very important factor in terms of managing the condition. So what kind of foods are contraindicated for somebody who has lupus?
I teach my patients to stay away from alfalfa sprouts, and the evidence is not very strong, but an interesting study occurred in the 80s where they were looking at L-carnitine, which is high in alfalfa sprouts, to prevent heart attacks and strokes and lower cholesterol, and a lady developed lupus-like disease. So they then just studied it in macaque monkeys, and half of the monkeys that were fed a high diet in alfalfa sprouts developed nephritis and autoimmune hemolytic anemia and positive double-stranded DNA antibodies. And Dr. Michelle Petrie in Baltimore, she did an environmental study and saw an association between alfalfa sprouts and lupus. So I recommend that my patients avoid alfalfa sprouts as well as mung bean sprouts, which are also high in L-carnitine. And that's the main food I recommend avoiding.
And I think, although not specific, just like any other disease situation, eating healthy, so to speak, and for lupus, where there is a higher risk of premature atherosclerosis, I think people watching the fats in their diet and eating cardiac healthy is a good idea. And likewise, patients with lupus are given often, unfortunately, high doses of steroids, and we know that that can certainly increase the potential for obesity, etc. And so, again, trying to curtail some of the fats in the diet is probably a good idea.
Okay, thank you. Okay, we have another question here. Could you please explain the relationship, if any, about psoriasis and lupus?
Psoriasis? I'm sorry, was that psoriasis?
Yes, psoriasis.
I'll just say that there's no association. They're both caused by different genetics. However, sometimes hydroxychloroquine can cause psoriasis to increase. And so if I have a patient with psoriasis and systemic lupus, their psoriasis all at once get a lot worse, I might have to consider other therapies and going down on the dose of their hydroxychloroquine.
Yeah, I totally concur with that, because we have certainly seen patients with psoriasis on hydroxychloroquine. It gets worse. I completely concur.
Okay, thank you. And one of the, there was another question in reference to the slides, and yes, we'll be translating them into Spanish, so we'll have them available as well in the website for the program, for the Let's Talk About Lupus program. I have another question here. What would you recommend to women who actually have lupus and want to get pregnant?
So I'll handle that. So we have done many studies encompassing hundreds of lupus patients, and the first order of business is to try to be in remission. And you might ask, well, what constitutes remission? Everybody's a little bit different, but if somebody's disease has been stable, not requiring medications that may be contraindicated, and that's another discussion, what you have to stop. You may still have a positive DNA antibody, you may still have low complements, but the point is that your disease should not be flaring at the time that you consider pregnancy, and you should not be on extraordinarily high doses of steroids, for example, greater than 30 milligrams of prednisone. Well, and so conversation with your physician is of primary importance, and there are very few situations where we discourage pregnancy, and those may be a history of pulmonary hypertension, and if you have chronic and fairly abnormal kidney function, this puts you at higher risk for certain diseases of pregnancy. Discuss with your doctors about what medications you may have to stop. For example, you cannot be on mycophenolate mofetil. You may have to stop that, either to substitute for azathioprine or to stop the medication altogether. If you have had active lupus nephritis in the last 2 or 3 years, this may be slightly more dangerous. But we have come up with risk factors that I think we can confidently discuss with our patients about their chances of having a poor pregnancy outcome or flare. And some of these risk factors are, one, unfortunately, being Hispanic is a slight risk factor for having a more difficult pregnancy, for example, or delivering earlier than a Caucasian woman, but that's not something we can really fix. But it is out there, and that's why all lupus patients, particularly those of minorities, should be seeing high-risk obstetricians. The second is being on a medication that may help blood pressure. Some people are on these medications for reasons other than blood pressure, but that's also important that you stop a medication that might be called an ACE or an ARB, but just being on other antihypertensive medications will put you at slightly greater risk. Having something called the lupus anticoagulant puts patients at risk for poor pregnancy outcome. Having a low platelet count at the beginning of pregnancy, or as I stated before, being active. If you have none of these factors, your chances of having a healthy pregnancy are very similar to patients who don't have lupus. The things we worry about are the development of preeclampsia, which is a disease where you develop protein and hypertension, may happen in about 10% of patients. So those are just sort of some general guidelines.
Okay. Now, how long can people live with lupus?
People with mild lupus without major organ involvement can actually live a long, normal life. Many of our patients are actually clinically quiescent in remission. But as far as long-term prognosis in patients with severe disease, I don't think we have a really good handle on that yet. As far as I'm not sure what to tell my patients who have severe disease who I now have in remission, because unfortunately they do develop permanent organ damage. Jill, do you have any comments about that?
I would say, in general, I try to say very long lives, but you know, things are changing very rapidly, and one of the things that obviously has changed is transplant for kidneys. And a transplanted kidney can really be obviously life-saving and will make a big difference. And as you know, although you'll be on chronic immune suppressive agents, you can live almost a full life expectancy. So it really matters. What's important here is that if someone is really sick, even in an ICU, don't give up. I think that's another way of kind of looking at it, is the sickest of patients can actually recover to the point of minimal or even no damage. I think this is very different than, unfortunately, facing someone with metastatic cancer, at least presently. And I try to be very encouraging to the point of not really saying too much about foreshortening their lives, because that's actually rare, not common. Even though I showed that slide about the chances, it's really, for most patients diagnosed with lupus, I think they can expect to live a fairly extended and normal lifespan.
Very good. Now, what will be considered a flare-up, and will they have the same flare-up each time?
Most patients do have similar symptoms as their previous disease activity. But however, people can develop new symptoms. And for example, the patient I mentioned that I saw earlier today, she had oral ulcers, and that was a completely new manifestation for her. So it's important that patients educate themselves and that we educate them about all the potential symptoms of lupus. But you are correct that oftentimes it's the same symptoms over and over again, most commonly.
That's been our experience as well in New York, that there's a sort of mimetic pattern to people's lupus. Someone has a low platelet count as a dominant manifestation. That's likely to be the recurrent theme for that patient. But absolutely, be on the alert for anything new. Lupus can be tricky, and there are really no rules that lupus abides by, and that's why vigilance and understanding the different manifestations is so important.
Okay, we are running out of time, but I think we have a couple of more questions. One, how long can people live with lupus without treatment?
No one with lupus should go without treatment. That always scares the crap out of me. I haven't had very many patients die from lupus, but most of them were patients who didn't want to take medicines and wanted to take herbal products instead, so that always scares me.
I totally concur with that. I think at least our philosophy is, unless there's a contraindication, all lupus patients should take hydroxychloroquine. I'm hoping that's shared by my colleague, but that is pretty much what we preach here at NYU.
Absolutely.
And then the last question is, what are the most common brain diseases that are associated with lupus?
I'll leave this up to Jill. She sees a lot more.
Okay. So, first of all, one of the disclaimers I'd like to make is that headaches are not necessarily from lupus. That's a very important point, because I could have said headaches, but most headaches are not due to lupus. So unfortunately, lupus can cause a stroke. That is possible, and often it's in association with certain of the clotting antibodies that I mentioned, these antiphospholipid antibodies. Lupus in some patients can cause what we refer to as lupus fog, but keep in mind, even lupus fog may be because a patient is depressed and they're worried about the next day not feeling well. So a lot of this idea of cognitive impairment, that not thinking straight, you have to sometimes take a step back and say, how nervous am I about my disease? How worried am I going to be that it's going to flare? Also, some of the medications, for example, very high dose steroids, can also affect brain function. Unfortunately, though, there are seizures. Some patients experience seizures, and some patients do experience hallucinations and disorientation. But the reality is those very severe manifestations are very rare, probably not occurring in more than 15% of patients. And when people hear, oh, everybody with lupus has some brain involvement, I think that's pushing it a little bit far.
Well, thank you very much, Dr. Bayon and Dr. Thomas. We really appreciate your participation, and especially to providing such great information for the program. For the participants, we will have the slides available, and we also adapt them into Spanish so people can also send them to their colleagues. And then again, I want to remind the participants from Texas that they will be able to receive CEU credit. So we will send you the survey. Thank you again to the speakers, and thank you to the participants.
Thank
you very much.
Thank you.